As we continue down the lower extremity, our next stop is the knee and patella. The knee joint is made up of the articulation between the femur and the tibia. The patellofemoral joint is made up of the articulation between the posterior patella and the femur. As we look at the knee joint, we know that the patella is the largest sesamoid bone in the body. Our first injury that we'll look at are knee dislocations. A knee dislocation occurs when the femur or the tibia is displaced. These dislocations are very rare, especially in athletics, but they can still occur. When knee dislocations occur, other secondary injuries occur to the soft and bony tissues. When we have a knee dislocation, it usually occurs from direct trauma. An excessive amount of force is needed to separate the femur and the tibia from each other, and this usually occurs in falls, motor vehicle accidents, and high-intensity collisions in athletics. Signs and symptoms that we typically see: the athlete is in shock, they are experiencing excruciating pain, they cannot feel the lower leg, and circulation may be compromised. In addition, the knee can be severely deformed. Treatment, especially if the athlete complains of any sort of circulation problems or not being able to feel their lower leg, call 911 immediately because this can be a medical emergency. You need to treat for shock, stabilize and splint the lower extremity in the position that you find it, place an ice pack on the knee, and monitor the athlete as EMS is on their way. For prevention, they're not entirely prevented, so we can't say, oh, we're always going to prevent a knee dislocation. But what we can do is participate in strengthening exercises, maintain flexibility and range of motion around the joint, so we have the musculature around the knee to help stabilize and support the knee area. The ACL, or anterior cruciate ligament, is within the knee joint. The ACL attaches the tibia and the femur, and it's tightest in full extension. This ligament limits anterior movement of the tibia on the femur, as well as knee rotation. And when we look at injuries to the ACL, more females have ACL injuries than males, and there's a lot of things that could go into this, but you have an assignment this week regarding ACL injuries in women. So I'll let you kind of look at that information out in some additional resources. ACL ruptures most commonly occur during competition in non-contact sports, but they can also occur along with MCL, or medial collateral ligament, and medial meniscal injuries. When we have the medial meniscus, the MCL, and the ACL injured at the same time, we refer to this as the unhappy triad in athletics. For mechanism, we have two different types of mechanisms mainly in athletics. We have a non-contact, where the person is weight-bearing with the foot planted, such as wearing a cleat in turf or in grass, and they twist or change direction very quickly, and this causes that ACL to become ruptured because of that twisting motion. For contact, we can see in that picture that the ACL also could be injured when the lower leg is hit by another player directly in front, typically when we have the foot planted. They can also occur with a fall on the foot or landing from a height. Signs and symptoms: the telltale sign of an ACL injury is the audible hear of a pop. Athlete will say, hey, I felt a pop, or I heard a pop. That's really a clue for athletic trainers or emergency personnel to know that it's an ACL injury. They will feel immediate severe pain and joint instability when they attempt to bear weight or kind of walk off the field. But what happens is this immediate pain starts to go away. So after the initial shock of pain, they'll actually start to decrease their pain. When we look at treatment, it's not a medical emergency, even though they are in a lot of pain initially, but we want to make sure we treat them with rice, maybe get some crutches, fit them for crutches to help them walk, and refer them to a physician. For prevention, we want to make sure they have proper nutrition, muscular function, proper calcium intake, as well as adequate sleep. Typically, just being a generally healthy athlete will help prevent this type of injury. For posterior cruciate ligament sprain, this is on the opposite side of the ACL. So this is the back side or the posterior aspect of the knee. And what we see within the knee, between the tibia and the femur, is that the ACL and the PCL cross each other, making an X appearance within that knee joint. The PCL, remember, attaches from the femur to the tibia, but unlike the ACL, the PCL is tight in knee flexion, so it's the opposite. The PCL functions to control posterior tibial movement on the femur, as well as valgus and varus forces. And again, different PCL injuries occur more in males than females. For mechanism, there's a few. There could be a direct force to the anterior tibia while the knee is in 90 degrees of knee flexion. It could also occur in high velocity events such as car accidents, with the knees again flexed but hitting the dashboard, or they can occur in low velocity events when the athlete falls or is hit by an object at the anterior tibia while the knee is in flexion. Last but not least, the PCL can also be injured by a direct blow to the knee while the leg is in hyperextension. Signs and symptoms. They may complain of hearing a pop, or they may state that they heard a pop at the time of injury and feel severe pain. If they have grade 3 PCL rupture. If not, they'll have typical swelling, point tenderness in the popliteal area, as well as immediate loss of range of motion and knee joint instability. Treatment is very similar to an ACL. Again, not a medical emergency, but we do want to refer them to a physician. Most times, PCL is not fixed through surgery like an ACL. Some individuals can function without a PCL just fine, but you could also have surgery for the PCL and go through rehabilitation. For prevention, we want to make sure we have the same things we do for ACL injuries: adequate quadriceps and hamstring strength, flexibility, avoid falling on the knees, and wear protective equipment. The other two ligaments of the knee are on the lateral side. So we have the LCL and the MCL. So the MCL attaches from the femur to the tibia on the inside of the knee. And the deep fibers of the MCL are also attached to the medial meniscus. And we'll get to meniscal injuries next. But when we look at the MCL, these are typically injured with a valgus force, so a direct blow to the lateral side of the knee, forcing or opening up that medial side. The LCL attaches the femur to the fibular head, which is on the lateral side of the knee, and it assists in limiting knee rotation and extension. And when we look at this is the opposite mechanism than the MCL, but we have a varus force or a blow to the medial side of the knee. And when we look at these two, the MCL is more commonly injured because there's a lot more blows that you can get from the outside of the knee compared to getting hit on the inside of the knee. Signs and symptoms. The athlete may feel pain and point tenderness. They may have some swelling and ecchymosis, and they may complain of feeling the tibia shifting or sliding when they walk, which indicates some sort of joint instability. Treatment, same as ACL or PCL sprain. We want to make sure that they are referred to a physician, but we're going to typically take the steps of RICE, anti-inflammatories, bracing, rehabilitation, and strengthening musculature around the area. For prevention, again, make sure we have strong knee musculature and wear protective equipment. A meniscal injury occurs, or when we look at meniscus, we have two meniscus in the body. We have the medial and lateral menisci, and they're located on the tibial plateau of the knee joint. And really what the meniscus is, they're really fatty tissues, and they act as shock absorbers for the knee, stabilize and deepen the joint surface, and promote appropriate weight distribution when weight bearing, so around that knee joint. But when we have tears that occur to the meniscus, they often occur with other injuries such as the ACL or the MCL. When we look at specific mechanisms, the meniscal injuries occur when the knee is in some degree of flexion and then rotates while the lower extremity is weight bearing. These injuries typically do occur when they are deeper in flexion. So as you get deeper in flexion, the predisposition for this type of injury increases. The athlete can also receive a direct blow to the knee, which can cause a meniscal injury. And these are more common as you get older and older because the meniscus continues to break down as you get older and becomes weaker and thinner. Treatment, we're going to use the Rice principle, use crutches if they cannot bear weight, see a physician or for evaluation if signs and symptoms don't decrease in about a week or so. For prevention, we want to make sure we avoid deep knee flexion and rotation. So that same type of movement that caused the injury, we want to try to prevent that motion. Next, we have a patellar fracture. When we look at patellar fractures, they are typically caused by a direct blow. And when we have this type of injury, the fractured patella really causes an improper ambulation or walking for that patient. However, not just a direct blow can cause this injury. The quadriceps can also contract forcefully enough to pull on the superior pull of the patella and cause it to fracture or pull away from the other aspect of the patella. Signs and symptoms include immediate pain, knee appears in flexion. Athlete has an inability to extend the knee because the two different parts of the pulley system in the knee is disrupted. They have swelling, deformity, ecchymosis, and point tenderness around the knee. Treatment, we want to make sure we splint the area in the position that we find it. Apply an ice pack to decrease some pain. Treat for shock if they go into shock, as well as call 911 to have them transported. When we look at prevention, we can wear protective knee equipment during contact activities and make sure that we're using a proper form in our sport. We can also have dislocations and subluxations to the patella. When we look at these types of injuries, they often occur due to an imbalance between the stronger vastus lateralis muscle and the weaker vastus medialis muscle of the quadriceps group. And this imbalance causes the vastus lateralis to pull the patella laterally during motion. So because of that stronger muscle, it pulls it in that direction. Females or athletes are more prone to patellar subluxations due to their greater Q angle or that angle from the hip to the knee. And you can see that in that picture on the right-hand side. That Q angle, which is made up of those vectors, as that goes up, the potential for this to occur goes up as well. We can also have a direct blow to the medial patella to cause a dislocation. Specifically looking at dislocations, our signs and symptoms are like other dislocations. We have pain, deformity, swelling, point tenderness in the area, and the inability to move the knee. And for treatment, we want to make sure that we splint it in the area that we find it. We don't want to try to relocate it, especially because that's typically outside of our scope of practice. So we want to make sure that they're comfortable. Treat for shock if they go into shock, maybe an ice bag, and wait for EMS to get there. For subluxations, a lot of the same signs and symptoms as dislocations we'll see, such as pain and swelling, point tenderness in the area. But unlike dislocation, for subluxations, the athlete may complain of the patella moving in and out of that area because it is going back in and back out. So it's really jumping in and out of that groove or the tracking of the patella that's normal. They will have minimal or no swelling in this injury. For treatment, we want to apply ice and a compression wrap. The compression wrap helps to decrease that patella from jumping out of the track. Have the athlete rest and take anti-inflammatory medications. For prevention, make sure we have good balance between the medial and lateral knee musculature so we don't have one side pulling more so than the other side. Next, we have patellofemoral pain syndrome. And we look at patellofemoral pain syndrome. It's also called patellofemoral stress syndrome. And this is really just anterior knee pain around the patella. And I included this because a lot of people complain of anterior knee pain. They just don't know why. And if we rule out everything else, we usually typically say it's patellofemoral pain syndrome because it really doesn't have a definitive cause, and it is kind of an all-encompassing anterior knee pain. So patellofemoral pain syndrome does have an insidious onset with no definitive cause. However, it can be speculated that the patellar compression against the femur may cause it, improper patellar tracking during ambulation cause it, and there's a slew of other things within the textbook that you can see may cause this injury, but we cannot say definitively one thing causes all patellofemoral pain. When we look at signs and symptoms, we have pain between the anterior knee and posterior surface of the patella. We might get some grinding or grating, point tenderness around the back of the patella. For treatment, we really have to find out what is the underlying cause of this anterior knee pain. We could treat signs and symptoms all day, but until we could figure out that really underlying cause, we won't fully have the athlete heal from patellofemoral pain syndrome. So we want to apply ice, compression sleeve, decrease knee flexion, and treat and correct the underlying cause if we can figure that out. If we're really having trouble, we can refer them to a physician for further evaluation. For prevention, this is one of those things that's not entirely preventable because it may be caused by the anatomy of the athlete. So we can't change that anatomy. So it is their structural anatomy, and that's what they're born with. But we can prevent it with proper lower extremity conditioning exercises and wearing proper footwear. Patellar tendon ruptures are another type of patellar injury that we can see in athletics. Patellar tendon ruptures occur with the patellar tendon, and the patellar tendon attaches from the inferior portion of the patella to the tibial tuberosity on the anterior aspect of the tibia. When the tendon does tear, it may cause an avulsion fracture of the patella's inferior pole to occur as well. When we look at mechanism, the patellar tendon ruptures from a forceful sudden quadriceps muscle contraction that forces the knee into extension. It can also be ruptured from a fall when the athlete lands on the area. And it really occurs if athletes are predisposed with a weakened patellar tendon along with a forceful stretch or contraction in that area. Signs and symptoms. This is a pretty traumatic type of injury, so they may go into shock, so we want to make sure that we monitor for shock. They have immediate severe pain. They might feel or hear a pop. Typically, there is a visible defect because that avulsed patella can be causing a visible defect, ecchymosis, swelling, and point tenderness in the area. For treatment, remember, most likely they'll be in shock, so we want to treat for shock and call 911. We can also apply ice to the area and split the knee in the area that we find it. If it is a partial rupture, we can use our Rice principle, place the athlete on crutches, and make sure that we refer them to a physician. To prevent patellar knee ruptures, we want to make sure we perform quadriceps muscle group strengthening and flexibility exercises and really get good lower extremity conditioning. We want to make sure that we avoid unnecessary high impact, forceful contractions such as in jumping activities, and we have a proper warm up and cool down for that area. Patellotendinitis, or what is referred to as jumper's knee, it's an overuse injury that occurs from repetitive stress over on the tendon that develops micro tears within that tendon. These micro tears result in tendon inflammation. Patellotendinitis typically has an insidious onset, so we don't really know when it starts, how it started, but usually it is occurred with repetitive knee flexion, could occur with a quadriceps muscle overload. The athlete typically experiences pain between the inferior pole of the patella and the tibial tubercle. This pain arises at the beginning of the exercise, and usually pain subsides during exercise. So we do see that big jolt of pain at the beginning, and then it does decrease The area may be point tender, but little swelling does exist for patellar tendonitis. For treatment, we want them to rest and discontinue any activities that cause pain, apply ice and elevate the area, use patellar compression straps to help with that pain of it moving and rubbing over and over again, causing those micro tears. We can also take anti-inflammatory medications to reduce inflammation and pain. When we look at prevention, we want to make sure we strengthen and stretch the quadriceps muscle group as best that we can. We can also use proper biomechanics, skill, technique, and progression when exercising. Our last injury that we'll look at, or last two really, are Osgood-Schlatter and Sinding-Larsen-Johansson diseases. And when we look at these two diseases, they're very similar, but they occur at different aspects at the patella. Osgood-Schlatter disease is an inflammation of the athlete's tibial tubercle apophysis, where it attaches to the patellar tendon. On the other hand, Sinding-Larsen-Johansson disease, it's not as common as Osgood-Schlatter disease, but it occurs when there's inflammation at the patella's inferior pole at its growth plate, where it attaches to the patellar tendon. These diseases, both Osgood-Schlatter and Sinding-Larsen-Johansson disease, occur because adolescent boys grow rapidly and it takes a while for their muscles to catch up to their bones, and they cause pain in this area. When we look at signs and symptoms, we have pain that resolves at rest, so we have more pain with activity, point tenderness, swelling, and a bump due to bone deformation or bone formation because that bone is growing so fast, muscles can't keep up with it, so that tendon really rubs over that bony area and causes an increased bone formation in that area. For treatment, we're going to make sure that we apply ice to the area, decrease activities, avoid activities that cause pain, decrease our intensity of activities for a period of time and slowly work our way back into them, and take anti-inflammatory medications. If really these conditions worsen or they don't get better in a few weeks, then we're going to make sure that we refer the child to a physician in case anything else is going on. For both of these, remember, they're not really preventable because as they're growing, you can't stop their growth. So the best way to decrease these is to progress our intensity of activity slowly for adolescent athletes who are growing rapidly, and make sure that we have good strengthening and stretching in that area.